Good morning. This will be the tutorial video for Nursing Research Week 3. This is going to be a week where we transition from looking at PICO questions like we did in Week 1 and trying to formulate the questions that we're going to ask, and Week 2 where we started looking at qualitative research, seeking to understand phenomenon or groups, or using grounded theory as a way to explore a phenomenon and seek to create a theory out of it. So qualitative that we looked at last week, which is level 5 and 6 evidence on that pyramid. And this week we are going to transition into what is considered level 2 and level 3 evidence, which is quantitative evidence. These are randomized clinical trials. These are experiments and quasi-experimental designs. So as we prepare for this week, I want to let you know that you will have a literature review grid that you will need to turn in this week, as well as your first quiz. And so let me share with you a couple of documents to go over here to start us out. Let's start with the lit review grid here. You saw this last week, so this should look familiar to you. Last week we did the article Becoming Normal, and now for week 3 as we transition, it says right in the title, so here's hint hint, a randomized clinical trial of education, or MI, which is motivational interviewing based coaching, compared to, so again, this tells us this is an experiment. We have an intervention that we're going to do compared to the usual type of care to improve cancer pain management. So again, this is Appendix A in your textbook. Here are the pages. Make sure that you read that article and then do your best to try to work at completing this literature review grid. And we will, again, as the week concludes, go over that. I will upload another little tutorial video where I go over kind of what things should be in which boxes here so that you can kind of follow along with me. So that is your literature review grid for this week. The other thing that I want to share with you, as I said, you have a quiz that's due this week for week 3. So I have created a study guide for each week that you have a quiz. Print this off if you would like, or open it up and fill it out. And this should help you be fairly successful. These quizzes are open book quizzes. You have about 2 hours once you start it to complete the quiz. The quizzes are only like 10 to 14 questions long. They're not very long, so 2 hours should be more than sufficient for you to be able to complete these quizzes. So for week 3, I want you to be able to define what the term theory is, know what qualitative research is, what are appropriate study characteristics for qualitative methods, how do we know when data saturation has been determined, qualitative research is designed to describe what are the elements of critiquing a qualitative research study, why should nurses who do not conduct research understand the nursing research process, what is the primary difference between independent and dependent variables? Again, that will be much more important here as we get into experimental design. Knowing your different levels of evidence, again, that's in your textbook, and we will go through that and review that again this week in the PowerPoints, so know that. And then just briefly to kind of review this idea of a null hypothesis. Again, simply stated, a null hypothesis is when we state that we anticipate that we will not see something, or this will never happen. So your hint here for this concept of null hypothesis is it's kind of a negative connotation. So it always uses the word no, or a variation of that. So hopefully this helps you in kind of preparing for your week 3 quiz. I'm going to transition us now into our PowerPoints for this week, again, where we're kind of starting to look at quantitative methods, and we will do chapter 19. It's a bit of a review on some kind of statistical concepts. it's more just to help you if you run across studies that have these sort of things that you could review back to this. It's really nothing that we are testing you on in this class, and it's a little bit higher level than really where we're trying to focus for this class. The main point for this class is that you are able to gather these research articles and really start to kind of pinpoint what kind of article they are, what sort of critiquing methods you might use for them. So let's open up PowerPoint on Chapter 9 here. So as I said, here as we start Chapter 9, we are going to be looking at experimental and quasi-experimental designs. The criteria for these is that the researcher is actively intervening to bring about a desired effect. So again, with that independent variable that we are actually manipulating something in experimental designs to bring about a desired effect. So the intervention is tested to see if it makes a difference. The whole purpose of experimental and quasi-experimental designs are to be testing for cause and effect of relationships. And as I said before, these provide us level 2 and level 3 evidence. Let me show you that pyramid again. This is on page 15 in your book. This is something you might want to consider printing out this slide and having it handy, because it's something you'll be using this entire class as we try to understand the different levels of evidence here. So as I said before, last week when we were looking at qualitative, you can see here levels 5 and level 6 talk about qualitative studies. A level 6 qualitative study is one single study. A level 5 is where there's a systematic review of a number of studies. Level 7, as I might point out again, is simply literature reviews of people that are just reviewing the literature to see what others are saying out there, the opinion of authorities or reports of committees. So again, a literature review would be a level 7. What we're going to talk about today, as I said, is level 2 and level 3. So a well-designed randomized clinical trial or a controlled trial without randomization, which are these quasi-experimental ones that we'll be getting into. How can cause and effect relationships be tested? There are 3 criteria that we need to infer causality. That the independent variable will affect the dependent variable. They have to be associated with one another. The cause must precede the effect. So again, the intervention comes before that which we measure, the data that we collect, the dependent variable. And the relationship must not be able to be explained by any other variables. In a true experimental design, you are going to be looking for these 3 things. This is important. You'll be tested on this. So the 3 properties of a true experimental design are randomization, control, and manipulation. A research study that uses a true experimental design is called this randomized clinical trial. Again, you may have oncology patients, or you may hear on TV, they're looking for test subjects to be a part of a clinical trial. That's what we're talking about here. What is the importance of randomization? Each subject in the study has an equal chance of being assigned to the control group or to the experimental group. Why would we want to randomize? It assumes that it's very important that the intervention variable be equally distributed between the groups. So we want to try and minimize variance and decrease any sort of selection bias as we are creating our groups. And something that's worth noting as you are thinking about the different research studies that you read is this idea of an intervening or a confounding variable, which is simply a variable that occurred during the study and it affects your dependent variable, but it was really not the intention of the study. These are important to keep track of and to make note of in the studies if you would run across anything like this, because of course it has a large impact in your study. Control, that you're introducing one or more constants into the experimental situation. You are doing this by manipulating your independent variable, random assignment, and use of a control group. Again, it's the control group that receives the usual treatment, or perhaps they are your placebo group. They are what you are measuring against. Manipulation is just simply the independent variable, that you're doing something to some of your subjects. The independent variable is manipulated when some of the subjects in your experimental group receive the intervention and others in the control group do not. The next couple of slides that we're going to look at are different types of experimental methodologies. Don't get terribly caught up in them. Try to use some kind of naming techniques to think of the differences in these, and I'll try and point them out as we go through them as well, but you will want to be somewhat familiar with these for your quizzes. So, type of experimental designs here. This is, again, your classic randomized clinical trial. So this is a very similar one that you would typically see, where you have a sample that you're selecting from your population. I want to look at cancer patients, and so I'm going to select a sample of them. We're going to collect our baseline data, and then we're going to randomize our subjects into an intervention group and a control group. Perhaps the intervention group is going to get a brand new state-of-the-art drug therapy, and then we are going to do post-intervention data collection to see did that really minimize the side effects, did that help fight the cancer, that sort of thing, versus our control group. So, classic randomized clinical trial. Of importance to note, baseline data is collected and then post-intervention data is collected. So we're collecting data at 2 different points. Next one is called Solomon 4 group. This one looks a little bit more confusing. Bear with me. You'll see some of the same things kind of repeat themselves. So again, we have our sample from our population. We then go ahead and we randomize our subjects. We are collecting baseline data in this top group, and in the bottom group, we are not. So only 2 of the 4 groups are getting kind of baseline data collected. We do an intervention and a control, and then we collect post data on all of these. Some drawbacks of this is, again, anytime we're doing multiple groups like this, it's expensive to do a test like this. And then we also have to take into account, which is kind of what this is looking at, is if I do some kind of baseline data collection, does that predispose my group to being more successful in completing something from the post-intervention kind of data selection? Does the fact that I am gathering baseline data somehow skew the fact that I'm going to gather data at the end? So what if the pre-intervention testing itself is what causes the change? You always just kind of have to take that into account. The next one we're going to look at is something called after-only design. Again, the names are pretty straightforward here on what you're doing. We have a sample from our population. We are randomizing into an intervention and a control. There is no pre-testing here. It's after only. After only testing says we only are collecting data after we do our experiment. Again, the assumption that we have to make when we use a design like this is that the 2 groups really weren't all that different prior to the intervention. We have a pretty homogeneous group, and that this should really be true if you have a very large group in which you're working with. Strengths and weaknesses of experimental design, which is what we studied there with those 3 types. It is the most powerful for testing cause and effect relationships due to use of control, manipulation, and randomization. But it's also, as I said, very costly and complicated, and sometimes it's just not even really feasible to be able to implement these true experimental studies. So, given that, sometimes the best thing that a researcher can do is to do what is called a quasi-experimental design, which also tests cause and effect, but something from the randomized clinical trial is missing. So perhaps you're not able to randomize your group, or perhaps there's not a control group. So anytime you have a lack of a control group, it makes the evidence a little bit less convincing, which is why this is coded as level 3 evidence rather than level 2 evidence, as we saw in true experimental design. Similar to those 3 different models that I showed you, quasi-experimental designs have similar modeling of how they approach doing their experiments. So let's look at a few of those. This one is called a non-equivalent control group design. We have an experimental group and a control group. Again, here you see we're collecting baseline data. In the experimental group, we do an intervention, and then we collect data again at the end. So we are just comparing kind of based on our baseline data here and the intervention that we're seeing. Here is a one group only pre-test post-test design. So we have our experimental group, we collect kind of some baseline data, we give them an intervention, and we collect the post data. There's no control group, there's no randomization. Here is a time series design where you would do over a length of time for people. You have an experimental group, you collect a set of data, perhaps 6 months later, you're collecting more data, you do some sort of intervention, and then you collect post-intervention data again, perhaps a year after, year and a half after, so longitudinal kind of study here. Strengths and weaknesses of quasi-experimental designs. Again, these can be much more practical, less expensive, they're generalizable. Sometimes these are our only feasible alternative because they are really adaptable to the world in which we are functioning in. You can replicate the study, which can help strengthen the evidence, but we might be less able to determine cause and effect. There may be some confounding variables in here that we need to take into account. Let's look at how we go about evaluating experimental and quasi-experimental designs. Again, if you're reading an article, you want to be able to kind of think of evaluating that. So here's some of the questions that you might think to ask yourself. Was there random group assignment? Was there an adequate sample size? Did they kind of start with a homogeneous sample? How pure was their data collection methods? Did they control for their variables? And do you feel like the evidence is likely to change your practice? For any trial, you might consider critiquing, was the design appropriate? Again, did they pick kind of the right modeling to use for this in your estimation, given kind of the financial constraints that they were dealing with? Was it pragmatic for the sample and the setting they were using? Was there a detailed description of what their intervention was? Did they describe what the intervention group was versus the control group and kind of where the differences lied? How did they, again, maintain their purity of their intervention, and was there any sort of descriptive power analysis with it? Again, looking at the different type of design used, randomization, control, manipulation, was there any reason for you to start to suspect that there maybe was any confounding variables? Were all the threats to validity addressed in the study? Do they kind of do disclosures at the end of their study of what might have impacted their study? Especially mortality numbers should be addressed. And then, are these findings generalizable to the larger population of interest? Again, similar to what you do for experimental studies, you do for quasi-experimental. Again, what was the design that they used? Are there plausible alternative explanations? Did the author explain any threats to validity? What does the author say in addressing limits of study? And are there any other limitations that you can think of to the design that perhaps they didn't mention? So those are just questions that you ask in critiquing a study. Let me switch gears now here, and let's see if I can find All right, thank you. Let's switch gears now and we'll look at Chapter 19. Again, as I mentioned before, this one gets pretty kind of in the weeds into some statistical kind of models and so on. So we will go through it. Feel like you can use this as something to refer back to as you need to. Bear with me as we make our way through this, and again, know that this is kind of above where I really feel like we're at this point. So this is kind of trying to understand research results as you're reading them in articles. The first thing that we want to look at with an article is this idea of relative risk, abbreviated RR. Relative risk is really something where we're looking at the probability of an event in the treatment group divided by the probability of an event in the control group. We want to be looking for a beneficial treatment that will give a relative risk for an event that is less than 1. So again, if you are on a cholesterol lowering medication, what is the relative risk of having a heart attack? If it is less than 1, you are less likely to have a heart attack. That makes sense. I'm taking a cholesterol lowering medication because I want to reduce my risk of having a heart attack, less than 1. If it's greater than 1, you are more than likely to have a heart attack. So again, relative risk. We're looking for a number less than 1. The next thing to think about is this idea of relative risk reduction, which is another just calculation. Basically here, if our whole subset is 1, then our relative risk reduction is 0.36. We also look at this absolute risk reduction, the difference between the event rates in the two groups. So again, in patients that are taking cholesterol-lowering medications, the event rate for a heart attack is 15%. In patients who are not taking cholesterol-lowering medications, the event rate for a heart attack is 26%. Therefore, the absolute risk reduction is 11%, the difference between these two numbers. 11% of patients who take this medication will be spared a heart attack because they're taking a medication. The next number for us to look at is this number needed to treat. Number needed to treat is a number of people who need to receive a treatment or the intervention in order for only one patient to receive any benefit. So again, as we said in our previous example, 11% of those people, let me go back to it here. 11% of patients taking this med will be spared a heart attack because of using the medication. Out of these 11 cases, for every 9 of those people that are treated, 1 person will actually receive the benefit of this. So out of every 9, 1 person will actually be spared a heart attack because of being on this medication. Confidence intervals, again, this takes us back to statistics, is a range in which the true result is likely to fall. It's kind of one of those measures of central tendency. And again, confidence intervals are usually recorded as a 95-degree risk or of certainty here. So here we have an intervention group, a control group, and we have the relative risk interval here. The ones that we're going to look at are these 2 green highlighted numbers because the range falls above 1.0 here. You can see 1.23 and this one's right at 1.0. Anytime that this has a 1 in it, it basically means the confidence interval contains the null value of 1. And so these results are not statistically significant. So of all the things they were measuring, these would be the 2 that you would kind of throw out as saying, nope, these do not have significance, statistical significance to them. And that's what this box is saying to us too, is the relative risk is determined by a proportion between intervention and the control group. Therefore, the null value is 1. Any confidence interval that includes the null value means that the endpoint is not a statistically significant finding. When we are looking at diagnosis articles, there are 2 concepts that you want to think about too, and that is the concept of sensitivity and specificity. Sensitivity is really a measure of how well the test detects disease when it is really there. So if I am concerned that I have some kind of cancer and you are going to test me, I want to be fairly certain that if my test comes back positive, that's because I truly have this. I don't want to be alarmed that I received a positive test when I really don't have that. The inverse of this is specificity, which is measuring how well a test rules out disease when it's really absent. So just kind of the inverse of that. You can hear from time to time of tests that have high false positives, and you would want to counsel patients before you were going to give them a test that might have a highly false positive rate that yeah, you can have this test, but it may come back positive, which may lead you down a road of having further interventions that you didn't need. So it's important to know with your testing sensitivity and specificity. Here is a typical grid that you might see for these. If a patient has the disease, what is the likelihood that we will find it on the test? So here are positive test cases. 80 people truly are positive for this test. We have 5 false positives. And then the inverse of this, the specificity, if the patient does not have the disease, what is the likelihood that he or she will test negative? Again, here we have 95 true negative tests. These are called kind of positive predictive values and negative predictive values. And let me scroll us to the next page here where we look at these a little bit more closely. So positive predictive value. There are 85 people in this case, 80 plus 5, who test positive. 80 of them truly have the disease. So if we take 80 divided by 85, we have a 94% positive predictive value. So again, very high that there are few false positives. The inverse of this is the negative predictive value, which says out of the 115 people, we got 20 here and 95 here, that test negative, 95 of them, are truly disease-free. So our rate for non-predictive value is 83%. There are more false negatives in this testing than false positives. So just an interesting thing to kind of keep in mind as you're reading studies. The other thing to look at is odds ratios, which is the probability of developing the outcome or developing a particular disease. So if an odds ratio is less than 1, the event is likely to happen in the treatment group than in the control group. So this could give you odds that the treatment is worthwhile, that it's working, that you're seeing those events play out in the treatment group. If the odds ratio is greater than 1, the event is more likely to occur in the treatment group than in the control group. Is less likely to, I'm getting myself switched around here. If it's less than 1, the event is less likely to happen in the treatment group. So we're going to see this more in our control group. If the odds ratio is greater than 1, the event is going to happen in your treatment group. As I said, that's kind of a very high-level overview. Don't worry too much about that in particular. That's not quite the main part of what we're going to be working on for this week. I've got one more PowerPoint. All right, last PowerPoint here for this week is Chapter 20. Let's open that up here. This is going to be a repeat of things that we've kind of looked at in the past too, but it never hurts to kind of hear them again. So as we start to think about developing our evidence-based practice, we want to be conscientious and judicious in looking at the evidence that is out there and pairing that with our clinical expertise and, again, our patients' values in creating the best healthcare environment for them. So again, research, our evidence, our expert opinion, and our patient values. We want to validate current practices. We want to be looking at things before we change them in practice. We want to make sure that we're providing cost-effective and quality care. You've seen this model before. Steps to evidence-based practice for Milnick, again, that we create this spirit of inquiry, that you're asking those PICO questions, searching for your evidence, appraising your evidence, integrating that with your own clinical expertise, evaluating your outcomes, and disseminating your findings. It's really important that we work with one another as we try to implement evidence-based practices in our work settings, that we have people on board, that we have buy-in to the things that we're trying to implement, that people understand the importance of these. So again, in creating a team of people that might want to take on evidence-based practice, you would want to identify key stakeholders. Who makes the decisions in your unit? What type of changes do you think need to be made? Who's involved in making those decisions? Who's likely to lead or champion this implementation? Who can influence decisions? What type of cooperation is needed? This is where those unit-based councils can be incredibly important. Knowing how to do evidence retrieval, that we're looking at clinical studies, meta-analysis, integrative literature reviews, and existing evidence-based guidelines. So again, all of these things that I mentioned here of clinical studies, meta-analysis, integrated literature reviews are all considered to be level 1 evidence. We talked earlier in this presentation about level 2 and level 3. These are the step above where we're taking those clinical trials and we're looking at multiple clinical trials. And so using Cochrane Review as a starting point for this, different gold standard kind of documents is important. Looking for your key search terms and using the expertise of health science librarians. We've looked at our levels of evidence, and so we want to make sure that we are grading those depending on 2 things. The level of evidence, the study design, that's our pyramid that we'll look at in our next slide, and then our critique of determining how well the research was done, the validity, reliability, bias, and confounding. Again, here is this important triangle of our levels of study. As I said in this PowerPoint right here, we would be looking at these systematic reviews, kind of this level 1 evidence. This can be done as a group project of kind of critiquing research as perhaps a journal club or novice and experts paired together using students as they come into your units, graduate students, and as class projects, obviously. We are working in depth in this class on trying to use literature reviews and having kind of a critiquing table where we are identifying what the purpose of the study is, what the research questions are, those variables, descriptions of our sample and our setting, what the research design was, methods that they might have used, descriptions and findings. Before you're going to develop an evidence-based practice, you would want to make sure that your guidelines are kind of fitting the context that you're working in, that you perhaps offer quick reference guides on how to help people go about doing this, and use of clinical reminders. You would want to make sure that you have strong leadership that's in support of this, a clear strategic vision, visionary staff in key positions to help with this, a climate that's conducive to experimenting, to looking into these things that's not opposed to kind of changing the status quo. Ways of being able to capture the data that you are getting through your research studies, and then available resources to support any sort of change. The goal is to collect and analyze data with regards to how a new evidence-based practice is going into effect, and then to modify your practice as needed. Your evaluation should consist of process measures and outcome evaluation. And your findings have to be provided to your clinicians to either reinforce the impact of the change or to ensure that they're incorporating that into their quality improvement projects. Future directions, education must include knowledge and skilled use of evidence research in practice. That's what we're trying to kind of start nudging you down that road here. And that you have a professional responsibility for all nurses to read and use research in your practice and to communicate with nursing researchers about the many varied kind of clinical problems that you're witnessing as bedside nurses for them to start to look at. All right, we went over a lot here for this week where we're just starting to kind of investigate quantitative data. Again, good luck with doing your literature review for this week. Make sure that you are continuing to gather articles for the research topic that you are going to do for this class. You needed to pick your PICO question and be prepared to give a presentation based on literature review for your particular area of study. So again, continue to work on that. By week 5, I believe, you will need to have turned in your literature review grids on at least 3 articles that you are going to do for your final paper, which is due week 6, and then the presentations are due week 7. Again, do not hesitate to contact your professor if you have any questions about that final project.